Part of the Compass care team at the Mayo Clinic. What's Compass?
For Comprehensive Pediatric and Adolescent Support Services. Totally rolls right off the tongue.
Her interests include bioethics, pediatric palliative care, pediatric critical care, and medical education. And she's going to present today on palliative care.
Awesome. Can you guys hear me? Is it okay? More? Better? Worse? Good? Better? All right. So this is semi-interactive, okay? So I like to talk, but I don't want to bore you guys to death. So I'm going to ask you guys some questions. So hopefully you can participate. And then if you engage, then we'll be done faster, and then we all go to happy hour. This seems dangerous. I might start rapping or something. I'm just kidding. Okay. So today our objectives. So I'll tell you a little bit about palliative care, what that is, and then how it can be delivered in a home setting, which is what we're all here to talk about today, and then explore some opportunities for people to engage with palliative care for the kids they take care of at home. Here's the first part where we're interactive. So, what is pediatric palliative care? Anybody? Comfort stages for anybody at the end of a disease process. Okay, go ahead.
Just another layer of support for the family, the patient, and the medical teams to have another holistic approach to the patient.
So a layer of support for family and patients. Good. Anybody over there? Crickets? Yeah, go ahead. So you all heard that, right? No. Thank you. So you're talking about somebody who has sort of an uncertain diagnosis or prognosis, something that could last a long time, and we follow along, and the child could get better or it could get worse. Pretty much what you said, right? And we kind of follow along for those ups and downs. Pretty good.
I would say that pediatric palliative care is, with all these kids, no matter what condition they have, or whether it's life-limiting or potentially life-threatening or whatever, but it's incorporating quality of their life. It's allowing them to have quality of life throughout their life, whatever that lifespan is, and not only the child, but their family unit, their extended family unit, their friends, in a holistic approach.
My job is done. Good. Yeah, so sort of a quality of care, holistic approach for the whole family. Quality of life is an important part. Awesome. So these are some of the kids that I've taken care of over the years. And what do you notice about sort of all of them? They're at home, right? So what we try to do is keep them at home so that they can enjoy their lives and have quality of life. And a lot of them have extra things like a trach or G-tube or oxygen or whatever. You know, they come with a lot of medical technology, which is where nursing staff comes into play. Cool. So I'm going to show you a video, and I'll let some other people tell you about it.
For a 3.5-year-old normal, typical child, and we're leaving the hospital into this world of completely unknown.
My world was shattered. So I'm in the hospital room, and I'm just so angry and just and yelling and screaming. How did this happen?
Because when you have something that catastrophic happen to you, child and the things that will never happen. And I know for me, that's, as a mom, I think that's what's been so hard, is knowing Tyler won't go to college, and he won't get married, and he won't have kids. And dealing with that is hard, but they help.
They're like a warm blanket around your baby. No matter what your baby's going through, they are there surrounding that child, and every child is treated like an individual.
They're caring for our child and for us and helping us live life every day the best that we can.
Palliative care is my go-to team.
You know, you're not just a number, you mean something to them.
A nosotros nos han ayudado de casi todas las maneras posibles. Nosotros hemos tenido ayuda psicológica, ayuda económica, apoyo espiritual.
Just when you think that they've done everything that they can do and that they have serviced you in every way, they go above and beyond and do something that you just can't believe.
Palliative care is a discipline, it's a medical specialty. It is board certified.
But what we do is so intimate that families have to let us into pieces and parts of their lives that nobody but other family members get to see. And that sacred relationship and agreement that we make with this family that we're going to be your palliative care professional and walk this journey with you is unique in medicine.
Cassie has a lot of personality when you get to know her. She's not easy to understand if you're a stranger coming off the street, but she is ornery once you get to know her. We have 20 hours of nursing in our house a day, and we have no private life, but that's just how it is. She's a big part of our family, and I think if anything ever happened to her, there would be a lot missing.
In palliative care, as the American Academy of Pediatrics says, we focus on adding life to the child's years, not just adding years to the child's life.
You know, things can always happen, and that is one of the things that Dr. Freebert and the team really focus on. Like, you could go out and get killed in a crazy accident, but would you not live life because you might? And that's really helped us when we were struggling through the really hard times to really embrace who Tyler is and where we are now.
I didn't want whatever time Noah had to be filled with sadness. I just wanted him to have a happy life, however long it was going to be. Palliative care took away a lot of the stress out of the situation, and that's what they told me. We don't want you to stress about it, we just want you to enjoy the time with him.
Well, I've learned that don't let life get you down and live life to the fullest.
They're not here by accident. They got here for a reason, and they are here to do something. And it is sometimes accomplished in minutes, and sometimes accomplished in days. But those days are as sacred to those parents as the years are to any other parent.
Going through this process with Morgan, it was like water started to taste better, air started to smell better. It was like a brand new clarity on life, and things that used to seem so big to me were now small in comparison.
There's so much that you gain. There's a fight in your spirit that you gain that says no matter what we face, we have a resolve that says we're going to get through it. And it wouldn't have been there if Morgan hadn't shown us.
What do you think? So that kind of sums up palliative care, right? Kind of what you were thinking, maybe? Maybe not? So I think about what we do here, kind of in the same way that the video and what you guys might have already thought about, but maybe in another way that you haven't. So you have your patient, right? Somebody who's got some major medical problem. That's how they get to us in palliative care. Maybe a life-threatening illness. They've got a couple of parents, maybe some siblings, maybe some grandparents. But then there's some other layers to their health and well-being. And some of it is financial, right? They're always asking, how are we going to pay for all these things? And there's a medical bill at the end of their hospitalization. Church and faith, and how do they make sense of their illness and their diagnosis? School, some of these kids go to school. How do they tell their friends? How do they get to school and participate in school and interact there? Then there's the larger community, maybe some support groups that people interact with. This is sort of everybody's basic life, right? I mean, we all can identify with it. And we insert ourselves as a team. And there's the doctors, social work, nurses, child life therapists, chaplains, psychologists, psychiatrists. That's a team. So we don't operate as one individual or one person. We're a whole team and everybody plays a different role. And you could even throw in other layers like the primary care provider, the home care nurses. Everybody plays an important role in providing care for these families who are also fragile. So if we look at what the World Health Organization defines palliative care as, it's an active, total care of a child's body, mind, and spirit. So it's not just addressing a medical need or, what kind of equipment do they need to go home. It's their body, but also their mind, their psychosocial well-being, and also their spiritual care. It begins when the illness is actually diagnosed, which is a little bit different than with adults, right? So you had mentioned, somebody who's got a terminal condition, and absolutely that's true. But in kids, it's hard to know when terminal is, a lot of times, because they can be sick for a really long time, have lots of ups and downs. And so we often care for them over a long period of time, and we like to start when it's diagnosed. So somebody has something bad, some type of horrible cancer, they're born premature and have head bleeds, something like that. We get involved early so we can walk on that journey with them. It continues whether or not the child receives treatment directed at the disease. So a lot of times in adults, once they get to that terminal illness stage, the treatment for whatever their process is sort of over, right? They're not going to go to the ER, their DNR, whatever they might have going on for treatment or surgery. They're not going to do that. But with a lot of times with kids, curative treatment can continue. And there's actually laws that support that to continue. We address the physical, psychological, and social distress, and we're multidisciplinary. And certainly we're provided anywhere, but we like to provide it at home, because that's where they're in their comfort zone. And we're adding quality of life, which happens not in the hospital, but at home. It's appropriate for all children and families with life-threatening illness, and our goal is to enhance the quality of life. And our intent is neither to hasten or to postpone death. So they don't have to be DNR or giving up or saying, I don't want to go do this treatment or that treatment. They can do all of those things. We're there to go on a journey with them. Does that make sense? Okay. So to understand a little bit about what pediatric life-threatening illnesses are, we kind of have to look at death, which is sort of a depressing topic, but it gives us a clue about who these kids actually are. So in any average year, about 50,000 kids die. And about 10 times as many live with a life-threatening illness. So that's a good number of kids. And if we look at the deaths, the majority of them are infants, and then the other half is older. If we look at the causes of death, when we look at infants, a lot of it is the congenital or the chromosomal abnormalities. That's the majority, or complications from prematurity. There's some other things in there like SIDS, accidents, and infant death is any child that's died less than the age of 1. If you look at childhood death under the age of 19, you still get kids with congenital problems or chromosomal abnormalities. There's a big chunk that's homicide and suicide, which is very sad, but true. Cancer is actually a small piece of it, which is ironic in a lot of ways, that oncology is usually what people think of palliative care. Like that's what we do, kids with cancer that die, that's what we do. And it's actually really the minority of what we do. And then congenital anomalies is 7%. In a survey of palliative care teams, so to see what kind of patients were actually being cared for across the continent, the majority of them actually had neurologic disorders, which people don't necessarily think of immediately. When you think about kids who have cerebral palsy, bad seizure disorders, developmental delays, that kind of all fits in there. And again, cancer is sort of only a quarter of them, along with these sort of congenital perinatal abnormalities. And there's an increasing prevalence of young adults who have problems from childhood that are now living long enough to be cared for by sometimes with the adult palliative care teams when they have abnormalities from childhood. So what does it all mean? So childhood death is rare, especially when you think about nearly 2.6 million adults every year die in the country. So 50,000 a year is not a lot, right? So think about this for a sec. Does anybody fly on an airplane? Like 3 people? Okay. I don't like flying, but I still do it once in a while. So like sort of an average airplane holds like 400 people or so, right? So imagine if an airplane goes down. Like you heard about the one that crashed and was like maybe terrorists. Like we're all like, oh my gosh, all those people died and such a tragedy, what a horrible thing, all the families are mourning. Well, kids that die every year, that would be 128 airplane crashes in a year, or an airplane crash every 2.8 days. That's a lot, huh? Kind of morbid. I mean, it probably doesn't help my fear of flying, but that's okay. Now, if we think about kids who have complex medical conditions, which is going to be a lot of the kids that get home care, then you're going to have about a plane crash every 10 days from kids that are like that. Still kind of a lot. I like to show these statistics to people who tell me, oh, pediatric palliative care, you don't really do anything, kids don't really die. And then they see that and they think, actually, you're right. It's more than a lot. So what is a complex chronic condition? Well, it's a medical condition that can be reasonably expected to last at least 12 months. And so that could be several different organ systems, or it could be one organ system that's really severely affected. And usually these are the kids who need subspecialty pediatric care, usually end up in the hospital, usually in a tertiary care center like a children's hospital. Skip that one. So if we even go back in time, deaths overall for all children under the age of 18, the kids who have that definition of complex chronic conditions make up at least 15% of all the deaths. And again, only cancer is 4.5%, and sort of the other pile is a miscellaneous, kind of lots of different heart conditions, etc. And so these kids have a lot of medical technology. These are the things that you guys are going to be dealing with in the home care setting. So like G-tubes, central lines, trachs, non-invasive positive pressure ventilation, or ventilation. So a lot of them have multiple medical needs that need sort of that everyday nursing expertise. So can anybody think about a complex chronic condition that you would know of? Any ideas of what that might be?
Encephalopathy.
Sorry?
Encephalopathy.
Encephalopathy, good. Okay.
Cerebral palsy.
Cerebral palsy, absolutely. Anything else?
Epilepsy.
Epilepsy, good.
Spina bifida.
Spina bifida. Perfect. Congenital disorders of glycosylation, so like metabolic issues. Good. Pardon? SMA, awesome. Cystic fibrosis, absolutely. Good. So entities that have multiple organs affected, like an SMA kid or a metabolic disorder kid, or somebody who's got one disease, one organ affected severely enough that it affects everything else. Absolutely. And these are the kids you pretty much covered all of those. Complex heart disease, like you had mentioned earlier, these are all these complex conditions that we see both in the hospital and in home care. So where do these kids get palliative care? Well, a lot of times they start off in the hospital, and we get connected with them there, but then the majority of the time they're at home. A third of them get their palliative care at home. And so we try to minimize their time in the hospital if at all possible. And where do they end up when they actually die? Well, if they're an infant, most of the time it's the hospital, because most of the time they don't leave the hospital. But kids and adolescents, we try to get them home. And that's sometimes what parents want, sometimes not. But we try to get them home to be comfortable and around things that are familiar to them. So what does pediatric palliative care actually do when we do get engaged? Well, the majority of what we do is symptom management. So pain, muscle spasms, secretions, headaches, those kind of things. We really engage with that. A lot of times because providers get a little uneasy when there's lots of different medications involved. That's sort of our area of expertise with handling a lot of pain medication, seizure medication, medication interactions. But a lot of times it's just communication. Asking people, how's it going? What's stressing you out? What's on your mind? Most doctors don't take the time to ask those questions, right? They're in and out. What's going on? What's their symptoms? Okay, bye. We actually want to hear what's going on a little deeper. Decision making, so if they're deciding, should we trach, should we not trach? Should we go forward with that surgery, should we not? Kind of walk through those decisions with them. Sometimes we coordinate care, and a lot of times we're involved in transitioning to home, so particularly if it is an end-of-life situation. DNR decisions, sometimes. Sometimes we get involved right towards the end of death so that we can facilitate symptom management at that point. And then bereavement for parents and siblings. You all know what bereavement is? Yeah? Anyone not? Okay. So what do we actually do? What's the effect? Well, they haven't done a whole lot of studies about what we do in the home setting. But at least we know some of the studies about what we do in a hospital. If a patient is appropriate to go to hospice, we are able to engage those discussions more frequently, more readily, and then we can hopefully get kids enrolled in hospice a little bit sooner. 22% more discussion about that. An earlier DNR order, which may or may not be a great goal, but we have those orders placed a little bit earlier than if not. Fewer deaths in the ICU, which we kind of think translates into a cost savings. So, and maybe infer that it's a better death experience for the family if it's actually getting home. The parents perceive that their child suffered less pain in about 20% of families. To me, that's a huge win. Parents felt more prepared during the child's last month of life and at death. In the home, in the few studies that we do have about home, parents perceive that there's a positive effect of quality of life, a positive effect on the quality of life at the end of life experience and during bereavement. So really enhancing that time that the parents have with their child at home. And then they're 5 times more likely to participate in planning the child's location of death, which is really important. We think that they get engaged and we're able to anticipate and talk about it and walk through what that's going to look like. This also associated with better experience at the end of life and less prolonged grief, which I think everybody would find valuable. We address the parents often because critical illness or chronic illness really changes the role of parents, right? So parents are supposed to make it all better. And when they can't do that, then they're changed in their role and their identity. Suddenly they need the nurse to do things, or the medical team needs to do things that they couldn't do previously. And so what we do is try to find ways to engage parents so that they can be equally important in the treatment team. We talk about their fears of the child suffering, and their uncertainties about what's going to happen and what death might look like. And then certainly communication and information delivery is always a problem when there's lots of subspecialists involved. And a lot of times we help streamline that, and we tend to say, hey, Mom or Dad, what do you understand about this? Does this actually make sense? Or did you hear something different? And you'd be surprised at how often parents really don't have a good understanding of what has been told to them. In terms of families, serious illness affects the patient's quality of life, but also the whole family's quality of life. Just because one person is sick, that affects the children of the other siblings and how they grow up. And if this is a chronic, long-standing illness, their behavior, their development, their psychosocial interactions with other kids change. And so we try to address those issues. Certainly the finance is a problem, the family structure changes. So if suddenly there's a nurse living in your house 24 hours a day, that's a whole lot different than what it had been before. So we try to support them through that. We like to get involved early because it's hard to predict death. So in somebody who has a sudden, unexpected condition, so say car accident, you look at this graph here, health status is on this axis and time is here. So this would be like all of us in this room, generally healthy, doing great, suddenly die. Hard to predict that, right? Now, if you have a potentially curable disease like cancer, you might be going along just fine, have some symptoms that come up, you get diagnosed somewhere over here, and then you get some chemo, you don't feel so good, but then maybe you make a recovery, maybe have a little setback here, and then recover, but not all the way back to where you were, and then eventually you die. Hard to predict if this was going to be the end point or this was going to be the end point. So we like to get involved sooner so that we can walk on that journey with the family. Now, if you have a congenital condition or something that was perinatally or intrauterine diagnosis like trisomy 13, you might know about that. Quality of life was never good, and you died shortly after birth or in whatever that time frame might be. This is the kind of kid that we see all the time, somebody with a progressive condition like muscular dystrophy, SMA, cerebral palsy. These are the kids that make it really tough for us because here they are diagnosed somewhere in this area, but they keep having these setbacks and they never quite get back to their previous baseline. And it's really hard to tell, are they gonna die here, or is it here, or is it here? So it's helpful for us to be involved sooner so that we can see these ups and downs and help prepare the family, or actually talk about, remember last time when we were scared that they weren't gonna do well and they bounced back? Well, this time might be different, or maybe it'll be the same. And we kind of walk through things with them. So does that all make sense? Yeah, okay. And really our ideal is to provide supportive care over time. And I love this slide because this is exactly what we do. There's sort of this continuum, and when somebody starts off being sick, we try to help them and cure them and fix them and do whatever we can to restore their quality of life. But as time goes on, and the acute turns into chronic, and chronic kind of gets worse and worse, and you get closer towards death, the palliative therapies become more important. So in the beginning, a lot of times, we're not doing a whole lot. We're getting to know the family and the siblings, say, how's it going? What can we do to help you? And then as things start declining, we start taking over a little bit more. And that's really the heart of what we do. Does anybody know what hospice is? Anyone? And don't read the slide. Sorry. It's geared towards what? I'm sorry. So yeah, it's really more towards like, not we know that we're close to death? And usually we think about referring people to hospice when they are terminally ill, and we expect them to have 6 months or less to survive. Now, is hospice a place? Okay, good. So it's an insurance benefit. Now, in some countries, and even there's sporadic places in this country where hospice is a place. It's like a house. And that tends to be more common in like Australia and maybe some places in Europe where there's actually a place where people can go for their end of life. Not so much around here. But it's really, when we talk about hospice, it's an insurance benefit. Now, in adults with hospice, if you go on hospice, you are usually DNR, and you are accepting that it's all comfort care, which I hate that term, by the way, because comfort care just sounds like, oh, we're going to do nothing except fluff your pillow, you know? It's kind of a weird term. But for kids, that's not true. So hospice might say, well, they have to be DNR'd for them to enroll. Not true. They don't have to be DNR'd. They don't have to be giving up. They can go and still get curative therapy. There's a law for that. So they can still go to the hospital, they can still go to clinic, they can still get medications to fight their cancer or whatever it might be. And wanted to tell you a couple of misconceptions about palliative care that I hear a lot from people, that the child needs to be dying. No, they can be living and can be trying to live and fighting to live. They do not need to be giving up. They do not need to be DNR or DNI. They do not have to be going on hospice. It's not just for terminally ill. And it's not, if people say, well, I still have hope, and I'm hoping for a miracle. Great, I am too. But in case that miracle doesn't come along, let's prepare ourselves. That's how I approach that. You got a lot today. Big day. So you're like at the end of the rainbow, right? The pot of gold is happy hour, right? Okay. So, a couple of things that I'm cut off.
Hit the bottom of the microphone. Push the bottom of the microphone.
Okay. Is it working?
Push the bottom of the microphone.
Yes? Yes. Okay. So, ideas for home care, for when you are doing palliative care at home. You guys are intimately involved with these families, far more than me or any other person at the clinics or the hospitals ever are, because you're there, you're in their home, you see the symptoms, you talk to the parents, you hear their little mumblings under their breath or what they're really truly thinking and probably are afraid to tell somebody. That's when it's usually important to hear from the home care providers, to hear, you know, I think that they've got some concerns. I think they think that the child's not doing well. Because families always know way before we do that their child is dying or things aren't going well. Families always know way before we do. And so you hear that, or you say, you know, boy, this kid always seems in pain and nothing we're doing is helping. Can't we do something different? That's super helpful. And if you ask your families open-ended questions, how are you really doing with this? Does this seem to be too much for this little girl or this little boy? That's helpful because then you can get the first insight into how these families are thinking and how they're coping. And you can bring that to their primary care provider and say, look, I'm wondering if we need to think about palliative care for this family. Now for us at Mayo, we changed our name from palliative care to compass care because there's so many sort of misnomers or misideas of what palliative care is. And as I mentioned before, our acronyms, you know, the last two S's are supportive services. So the idea of palliative care is like nowhere in the title, so that people know we're here to support them. We're not here to shove a DNR down their throat. And we're here to help with their symptoms and walk their journey with them. So if you are at home with them, you can help provide that idea to their primary care that maybe this is a good referral that needs to happen. Or if you're in home care, you could even think about working for hospice or pediatric home service or volunteering for a local hospice, because they always need volunteers to go sit with patients in giving them some respite and relief. So thank you very much. Any questions, ideas, comments? Yeah.
Seems like sometimes with the pediatric population, there's a time frame where we're still trying to get to that diagnosis.
Yep.
Or waiting for the genetic testing to come back, or they have to just watch test results for 6 months. So can Compass or palliative care come into play in that waiting game as well when the child's having symptoms but there isn't necessarily a diagnosis?
Absolutely. Yep. They can still be going through a workup, and they don't have to have an absolute diagnosis, because again, we're there to support them. We're not there to say, and here's the guillotine. Like we're here to just walk on the journey with them no matter what it is. Absolutely. Good question. Yeah.
You said a referral from a PCP is
Yeah.
necessary. How do you feel the community of PCPs are becoming more comfortable with palliative care, or what's the evolution there?
Great question. I think a lot of primary care providers are strapped for time. So they don't have the ability to sit down and ask these deep questions. And so when you say, I'm wondering if this would be a good time for this, a lot of them will be receptive. Now some people aren't, because they think, I'm country doctor, always handled everything, I don't need them. Even some of our subspecialists are like that. And that's okay. They don't have to be receptive to it, but the way I phrase it is that this is about the patient and what we can do to help support them. It's not, we don't take away from what the primary care provider's role is. We're just additive to them. And we like to work with them because it actually works out quite nicely when the primary care provider is able to say, you know what, I think I agree with Dr. Schiltz that we might need to think about going a different direction in terms of our goals of care. And that has worked out very nicely for me in the past, so that's how I try to approach them if there's any hesitation, that we're really a partnership. We're not here to replace them. Good question. Yes, please.
A lot of these little kids that we take care of are code, and we're gonna grade them if we do CPR.
Yep.
And that's what we do, is give them full code. What do you do there?
Yeah, so if we think that doing CPR could be harmful and or futile, for lack of a better word, we'll address that. And
You will.
absolutely, anybody can. Absolutely, you mean like as a home care nurse?
Yeah, but those are the home care nurses that end up on the curb because they want to do that. No, parents don't want to do that.
What I would say is I would ask them, have you thought about that? Have you seen it done, or do you know anything about it? Just wondering what you think. Rather than saying, hey, I don't think we should do this. Just ask them. Open-ended questions always take you a lot farther. So you just say, have you given that any thought? Because, boy, those ribs are fragile on your baby. I would really be scared about that. And then they might ask you, well, what is it that you do with CPR? It's not like, Grey's Anatomy or whatever. Then you can educate them and then say, maybe you should talk to your doctor about that, about maybe not doing that. Sometimes that's the best way, is just, open-ended, and then if they have more questions, say, hey, why don't we make an appointment to go talk about that exact thing? Does that help? Yeah.
Can I add to that, when I've done admissions for agencies I've worked for, I was required in certain states to bring up DNRs, and I always said that regardless of what the decision ultimately is, that the conversation should be had when you're not in an emergency room.
Absolutely.
Have it when you're just talking and trying to make this is what you're going to do, and that just because one family says we're going to not resuscitate, another family says they are, it's like comparing apples and oranges. Yes, they're both families, so they're kind of part of that group family, but they have so many different things that you can't really compare one to the other.
Mm-hmm.
It needs to be what that family feels is best. And then as a clinician, you
That's a great point. And remember that every family is going to cope with their grief and their decision differently. So some families need to go through, like they need to know everything possible was done. Even though all of us are saying, well, that's a stupid decision, they're never going to survive that. But they may need to know that everything possible was done. And as medical providers, that may be frustrating, or you feel like that seemed maybe even harmful to this poor child. But at the end of the day, it's the parents who have to live with that decision. And it's a hard one. Was there another question? Yeah, go ahead.
I was just wondering, more on the practical side of what you do or the Compass Department does.
Mm-hmm.
Are the visits mostly, at the clinic, or do you go out to the house? What is a typical role for a nurse maybe working in your agency? Do you replace care coordination in any way, or what's kind of the nuts and bolts of it?
Yeah, that's a great question. And I think every program is different in terms of what they do. And our program is a little bit on the young side. There's other programs across the state that are far more mature and have been around a lot longer. Children's in Minneapolis is one of them that has been probably one of the palliative care leaders for 20 plus years at least. Ours is a little bit on the younger side. So we don't tend to do care coordination. I'm not sure about Children's in Minneapolis if they do or they don't. Do you know, Roy, do they do care coordination? Yeah, I don't know either. But so some places might. We don't. And we don't replace what the primary team is already doing. A lot of times we start off with visiting them in the hospital as our initial consult or as an outpatient consult. And then we tend to try to make it as easy as possible for families to communicate with us. So whether that's through the email portal or it's by phone calls, a lot of times we don't even ask them to bring the child in if they are just coming in to talk about a DNR. And you don't need to bring the kid, you just come in and we'll talk about it. So we kind of accommodate to what the family needs. Does that make sense? And we go to home if we can. Now for us, our catchment is huge. So a lot of our patients are coming from many hours away, so we can't get home to all of those. But we'll try to work with their home care providers to give whatever support they need. Absolutely. Great, any other questions? Yes?
Who are some of your essential participants in the Compass program, and how long does it take you to get it off the ground?
Great question. So our program actually started in 2007, and it was very rudimentary. I arrived at Mayo in 2011 and took over, and it took us about 2 years to actually get physician time before it was just volunteer. And now we just hired a nurse care coordinator who will take care of all of our patients, but then also do the bereavement after death care as well. So that was just hired. That took us another year or so to get that approved. And then we have psychologists and social workers that help us, but they're not actually, I'm not paying for them, but they work with us. We have a core group of people that work with us. Primarily chaplain, psychologist, social worker, and we have a couple of complementary medicine folks like music therapy, massage therapy, and we work with our adult integrative medicine as well, because a lot of our kids get acupuncture and all that stuff. So, great question. Okay.
Thank you very much for that great presentation. So before we close here, I want to thank everybody for coming from hospital to home. I hope you enjoyed the presentations today. Make sure you fill out the evaluations and drop them off on your way out. There's going to be some adult beverages outside for cocktail hour here. There's also going to be a career open house and SimLab opportunity, as well as raffles for some gift cards. And you'll be able to find photos from today on the PHS Facebook. Thank you.
Really good.
Thank you.